Well, hello everyone, and on behalf of the American College of Cardiology and the Center for System Improvement, I would like to welcome you to this EMS and Systems of Care webinar where we take on talking clinical quality to the next level. My name is Tim Phelan. Our other commentator, Tom Boothlet, unfortunately is not able to join us here for this session.
But we're always delighted to have Tim Phelan on these webinars. And for those of you who don't know Tim, he's a renowned EMS educator with an extensive background in EMS cardiology. Tim has authored several textbooks in the area and teaches 12-lead EKGs and EMS cardiology all over the world and has taught tens and tens of thousands of students all over the place. So excellent bona fides from Tim to work with us on this seminar. So I'm glad you're able to join us, Tim.
Absolutely, my pleasure. Now, so today we're going to talk about implementing time-sensitive care coalitions. But before we get in, let's just acknowledge the obvious here. So as we record this today, it's March of 2020. And as you are well aware, everything is changing on a daily basis here. And after much reflection, Mick and the Centers for System Improvement, the American College of Cardiology, the real question was, do we proceed with this given all that's happening? And the conclusion was, as well, Mick's available, Tim's available, let's record it. So instead of our normal approach where we have a live webinar and people will be sending in questions, we're just going to record it since the work has already been done and make it available. So we're not exactly sure when you might be seeing this, but it's going to give you the flexibility to watch that webinar on demand, and it won't take away any of your time for serving the community the way that you're doing right now. So you watch it when your time and circumstances permit. And as I said, since it's not a live webinar, I want to really emphasize that you can still ask questions. So as you go through this, or when you're done, send your questions and comments directly to Mick at improvethesystem.com. Improvethesystem.com. And Mick is really great about responding to all those questions and comments sent by email. So, as you know, our presenter, as always, is Mick Gunderson. And as I tell folks, Mick was into quality before quality was cool. Okay, so he has been doing this for decades, and he's currently the president of the Center for Systems Improvement. Huge, diverse background in EMS, quality, as I mentioned, and specifically cardiovascular care. He's worked for all of the big hitters, and he's just a voice that people always tend to listen to. So, as the Center for Systems Improvement specializes in elevating the performance of community and regional systems of care for high-risk, time-sensitive conditions and providing EMS system assessment, quality improvement, and training services. So abundantly qualified for our session here today. So I will turn it over to Mick.
Well, thank you, Tim. Let's just go right into the didactic segment, and we'll come back afterwards and discuss it.
This EMS and Systems of Care webinar series is brought to you by the American College of Cardiology's National Cardiovascular Data Registry, the NCDR. They're getting ready to roll out a new service that takes support to EMS and Systems of Care quality improvement efforts for acute myocardial infarctions to a whole new level. For more details, visit acc.org/ereportsems. For this webinar in our series on taking clinical quality to the next level, we're actually going to build on some of the information from a prior webinar in our series, which was on structuring your system for quality. If you'd like to watch that entire webinar, you can access it and all the rest of the modules in this series at acc.org/ereportsems. Just scroll down to the resources section of the page and click on the View Series link on the blue bar. Today we're going to talk about implementing systems of care for time-sensitive emergencies, like those for STEMI, stroke, cardiac arrest, trauma, sepsis, and the list goes on. I think it's time for us to rethink our approach to these systems of care and how we approach improvements to them. But to fully understand any of these systems of care and some of the underlying issues in improving them, we need to understand the nature of systems in general, how the elements of a system impact each other, and how these elements individually and collectively impact the properties of that system. This is something that's referred to in the academic literature as systems thinking. To help us get a handle on that, I'm going to show you a short clip from a lecture given by one of the giants in the field of systems thinking, the late Dr. Russell ACKOFF. If you watched our webinar from May of 2019, you will have seen this same 3-minute clip before, but it's well worth another look. We'll jump into his presentation where he's starting to explain what a system is and the implication that has for how we think about quality from a systems perspective. He's using the automobile and human body as different examples of systems. Please take note of several key points he'll make about what a system is and what determines its level of performance. And these are key to taking your efforts to establish and improve systems of care to the next level. So let's take a look.
The essential or defining properties of any system are properties of the whole which none of its parts have. For example, a very elementary system you are familiar with is an automobile. The essential property of an automobile is it can carry you from one place to another. No part of an automobile can do that. The wheel can't, the axle can't, the seat can't, the motor can't. The motor can't even carry itself from one place to another. But the automobile can. You have certain characteristics, the most important of which is life. None of your parts live. You have life. You can write. Your hand can't write. That's easy to demonstrate. Cut it off and put it on the table and watch what it does. Nothing. You can see. Your eye can't see. You can think. Your brain can't think. And therefore, when a system is taken apart, it loses its essential properties. If I bring an automobile into this room and disassemble it, although every single part's in this room, I don't have an automobile. Because the system is not the sum of the behavior of its parts, it's the product of their interactions. And that's been said here in many ways over and over today. Now, what does that mean? If we have a system of improvement that's directed at improving the parts taken separately, you can be absolutely sure that the performance of the whole will not be improved. And that can be rigorously proven. But most applications of improvement programs are directed at improving the parts taken separately, not the whole. The proof is complex, and I won't bore you with it. Let's just take a simple example. I read in the New York Times recently that 457 different automobiles are available in the United States. Let's buy one of each and bring them into a large garage. Let's then hire 200 of the best automotive engineers in the world and ask them to determine which car has the best engine. Suppose they come back and say the Rolls-Royce has the best engine. We make a note of it. Which one has the best transmission, we ask them, and they go run tests and come back and say the Mercedes does. Which one has the best battery? Come back and say the Buick does. And one by one, for every part required for an automobile, they tell us which is the best one available. Now we take that list, give it back to them, and say remove those parts from those cars, put them together into the best possible automobile. Because now we'll have an automobile consisting of all the best parts. What do we get? You don't even get an automobile. For the obvious reason that the parts don't fit. The performance of a system depends on how the parts fit, not how they act taken separately.
The point Dr. ACKOFF makes about systems performance being driven by how the parts interact, not by how the parts perform separately, is really important to fully understand. So let's think about that in context of our systems of care for time-sensitive conditions. As an example, consider STEMI systems of care, but it also applies to all of our other time-sensitive systems of care. The STEMI system of care is not driven by how well dispatch works separately from how well the field crews work, separate from the hospital, separate from rehab, and separate from secondary prevention efforts. We don't just add up their individual performances to see how well the system of care performed. Think of it more like the gears in a clock. The system performance is driven by how well the dispatch process interacts with field crews, and how they interact with hospitals and their emergency departments and specialty care teams, and how they interact with rehab and how rehab interacts with the secondary prevention efforts. All of these interactions across the entire episode of care determines how well the whole system performed. This has huge implications for how we design, manage, and improve our systems of care for time-sensitive emergencies. The fundamental purpose of a STEMI system of care and most other systems of care for time-sensitive conditions is to restore health and quality of life back to pre-event levels as much as possible. As we all know, STEMI is not an uncommon time-sensitive condition, and poor care can have serious long-term consequences, so getting it right is an important goal. So consider a scenario in which a well-intentioned EMS quality manager, recognizing the importance of STEMI care, decides to focus on improving EMS performance in STEMI care. Early in the effort to improve EMS STEMI care, they choose performance measures. They will use those to determine how good of a job that they're doing in EMS STEMI care, a reasonable thing to do. Several of these performance measures are listed here, but I want to call your attention to the last one, the EMS STEMI overcall rate. This measure refers to how often EMS declares a STEMI alert, but it turns out not to be an appropriate case. One issue is how to define what cases are and are not appropriate for EMS declaration of a STEMI alert. The American Heart Association's Mission Lifeline program recently published a paper on the pre-hospital activation of hospital resources for STEMI cases. This paper proposes a national standard definition for EMS overcalls on STEMI alerts. It defines them as cases where EMS declares a STEMI alert, but the patient does not undergo emergency angiography and is not diagnosed with myocardial infarction. Some have referred to such cases as activations without intervention. To measure it, you count the number of EMS STEMI alerts that were declared in a given time frame and put that number into the denominator. Then take the number of those cases where the patient did not get an emergency angiogram and place that number into the numerator. Do the math and you get the EMS overcall rate. So let's plug in some numbers as an example. Let's suppose that we had a total of 87 EMS STEMI alerts in a quarter, and of those 87 cases, 20 cases did not warrant an emergency angiogram. Doing the math, we get 23% as the STEMI overcall rate. Seeing that number, our well-intentioned EMS quality manager decides that their EMS organization should do whatever it can to get that number lower, much lower, as low as possible. After all, that number is a reflection on how well their EMS organization performs on STEMI care. The EMS administrator supports the goal of getting that number down as low as possible for their organization as well. A high number does not reflect well on them personally as the leader of the EMS agencies, nor does it reflect well on the agency as a whole when that number is high. EMS crews also want the number as low as possible. They don't want to get chastised by the emergency department staff or the interventional cardiologist for activating the cardiac cath lab team unnecessarily. So, with the goal of getting the EMS STEMI overcall rate as low as possible, they come up with a very simple and incredibly effective strategy. They will simply stop declaring EMS STEMI alerts, and as a result, the EMS STEMI overcall rate will drop to 0. But notice that their goal was centered on EMS performance. They found a way to get their number for EMS to be as flattering as possible. But reflecting back on Dr. ACKOFF's point about how improving the performance of a part of the system, when considered separately from the rest of the system, can actually decrease performance of the system, and we can appreciate how this example illustrates his point. We did make that EMS performance measurement as good as it gets, but without considering the impact on the overall system of care. They improved EMS performance to the detriment of the overall STEMI system of care. This detrimental impact on the system shows up as a spike in the number of EMS undercalls, cases where EMS missed opportunities to make STEMI alerts. Now, Still lacking an appreciation for systems and systems thinking, the well-intentioned EMS quality manager shifted their focus to reducing the undercall rate to as low as possible. Again, we need to have a standard definition for EMS undercalls, and the pre-act paper offers one. It proposes that EMS STEMI alert undercalls be defined as the cases where the patient was diagnosed with STEMI, they arrived by ambulance, they underwent emergency angiography, and met the pre-act criteria, but EMS did not end up declaring a STEMI alert before arrival at the emergency department. It was a missed opportunity to pre-activate the cardiac cath lab and save some time. So looking through the lens of EMS quality metrics and its crews by themselves, this is also an easy problem to fix. With a goal of setting the EMS STEMI alert undercall rate as low as possible, they choose another simple and extremely effective strategy. They choose to call an EMS STEMI alert on all patients. Now, the EMS STEMI alert undercall rate goes to 0. EMS looks great on this measure, but as a result of that, the overcall rate skyrockets. Discouraged but not giving up, our well-intentioned EMS quality manager goes back to the drawing board. But still lacking an appreciation for systems thinking, the goals and strategies are revised again. This time, the effort will be on getting both numbers down as low as possible. So with a goal of getting the overcall and undercall rates down as low as possible, they come up with a new strategy designed again to optimize EMS performance. They will try to make a better assessment of the patient before they decide if they're going to declare an EMS STEMI alert or not. They'll do that by giving several 12-lead ECGs on scene, spaced maybe 10 to 15 minutes apart. They'll also do some field cardiac biomarker tests and process the results in the field. As a result, they drive those undercall and overcall rates down as low as possible because of the more in-depth and comprehensive field assessment. But because they're not thinking systematically about the overall STEMI system of care and its overall objectives in returning patients to their pre-event level of health and quality of life, the scene times and total myocardial ischemia times skyrocket, and we end up with larger infarcts, and that leads to higher morbidity and mortality rates. Now, obviously, this directly conflicts with the goal of the STEMI system of care. But if we look at things through the lens of the system of care, we can more appropriately focus on something different. We can try to do things in EMS that are not centered on optimizing EMS, but on optimizing how EMS interacts with the rest of the system and contributes to the goal of improving things for the patient. Remember that system performance is driven by how well the parts interact with each other, not by how each part performs independently. This can be achieved by balancing undercall and overcall rates at a point where morbidity and mortality rates are minimized, not by measures of EMS performance in isolation from the rest of the system. But do you think my EMS examples are a bit extreme? Perhaps not as extreme as what you might think. Consider the reaction of EMS crews that get chastised by the emergency department staff or the interventional cardiologist for activating the cardiac cath lab team when they made their best assessment, but it still resulted in an overcall. It'll be human nature for them to shy away from pulling the trigger to declare an EMS STEMI alert again. At an organizational level, if the agency leader gets chastised in meetings with the hospital, there will also be a tendency not to implement a process to explicitly declare EMS STEMI alerts. This will allow the agency to dodge criticism and accountability. I submit to you that this does and is happening in communities all across the country. These are real problems and real opportunities for improvement by applying systems thinking to measurement and giving feedback that's focused on the system rather than the parts of the system or the individual worker at any level, as Dr. ACKOFF so strongly recommends. It's all about the system. So that example was about EMS. Surely hospitals are more sophisticated and above all of these sorts of problems. So let's consider a similar example at a hospital level. Consider a well-intentioned hospital administrator who wants their hospital to improve its STEMI performance. They embark on a similar journey. They have a set of performance measures pulled together. They will be used to assess how well the hospital is providing STEMI care. And I bring your attention to the last item on that list, the STEMI PCI mortality rate. Our well-intentioned hospital administrator, focused on their part of the system, the hospital part, wants to optimize the hospital's performance by getting the STEMI PCI mortality rate as low as possible. With that goal in mind, the hospital team undertakes efforts to bring it down. As they start looking at cases where there were deaths following emergency PCI, the team notices that many of these involved patients that had gone into cardiac arrest prior to the PCI. The indication for PCI in some of these cases was countershock refractory or frequent recurrence of ventricular fibrillation, and that obstructed coronary artery may well have been the underlying cause of the dysrhythmias. It might also have been the presence of ST elevation after pulses have been restored. But in either case, a hospital-centered strategy emerges. Stop performing emergency PCI on patients whose care has been complicated by cardiac arrest. They decide to manage these patients medically. As a result, the mortality rate from emergency PCI improves. But going back to our systems view, how does that decision impact the STEMI system of care and its objective of restoring pre-event health and quality of life to STEMI patients? Not so much. So, taking a systems view of the challenge to improve emergency PCI mortality rates, we need to have all of the hospitals in the system with emergency PCI services get involved. All of those hospitals need to consider this issue collectively as they all have the same challenge. They could agree to share the risk, with everyone agreeing to take appropriate cases emergently to the cath lab and not having hospitals or individual interventional cardiologists game the system by avoiding those high-risk cases. This levels the playing field, with hospitals not taking an unfair advantage over others by avoiding these appropriate but high-risk cases. They can also agree to measure the performance differently by separating out cases with and without cardiac arrest, maybe even include the cardiogenic shock cases, which present similar challenges. Those performance measures can be posted by hospital and by the system as a whole. That allows the system to accurately assess performance in a way that does not penalize hospitals or interventionalists from doing the right thing for these high-risk patients. And there's some national level issues here as well. If national performance measures are designed with systems thinking in mind, we can better recognize these unintended consequences and design measures in a way that promotes systems-level performance improvement. Separating out cases with and without cardiac arrest prior to emergency PCI into different performance measures at a national level will be a big help. And that systems perspective can have a very positive impact on STEMI systems of care. So there's several lessons here that we should all come away with. First, apply systems thinking to our improvement efforts. We can do that by thinking about the potential implications of your improvement effort and the effects it'll have on the rest of the overall system of care and its objectives, rather than just your interests or your institution's interests separate from the system. And with those points in mind, we can avoid optimizing a part of the system at the expense of the overall system. And one of the ways to help remind everyone about those points is by using systems-level performance measures in addition to the organization-level performance measures. Now, all of this does raise some very real and practical questions, like who gathers and aggregates the data from all of the different competing hospitals and other provider organizations? And why would any hospital or ambulance service or other provider organization put the interests of the community and system above the interests of their own part of the system? Well, sure, we'd like to think that duty and commitment would be sufficient, but we've seen the kind of part-focused behaviors we just talked about in EMS agencies and hospitals all across the country. Some of this may have been inadvertent, not recognizing the impact of such policies on patients, but I also know some hospitals steered away from the high-risk cases and fully understood the implications. And this is where many regions and communities now find themselves, trying to find practical and sustainable ways to address these kinds of questions. But there's some hope and progress to be had through a systems-level improvement strategy. Hospital accreditation standards can provide a path forward when they incorporate standards that require evidence of system-level efforts. This is more than hospitals just reaching out to EMS providers that bring them patients. Unfortunately, we do not yet see accreditation standards that require evidence of efforts where all of the hospitals and EMS providers in the catchment area are working together on measuring performance and engaging in systems-level improvement projects. And that's really what we're talking about here, establishing some sort of regional systems of care across hospitals, EMS agencies, and into the post-acute care phase with rehabilitation and secondary prevention. Remember, the goal of the system of care is to restore patients to their pre-event health and quality of life status to the greatest extent possible. So how does one go about establishing a regional multi-condition system of care? And how does that regional system of care go about establishing accountability for performance at a systems level? Now, there's a few stakeholders that are in an excellent position to help make such things happen. The top leadership from units of local government, senior appointed officials like city managers, county administrators, or elected officials like mayors, city council chairs, or chairs of county commissions. They have a bully pulpit that allows them to speak out on issues and bring people together to address substantive issues that impact the community. Having a reliable, effective, and efficient system of care for time-sensitive conditions certainly meets those criteria. Those senior government officials can also bring in the public health department, and the public health department on its own will often have the standing and political influence to get such things accomplished. After all, emergency care for time-sensitive conditions is a public health issue, as it requires resources across a community to effectively deliver care. And don't forget about who pays for most of this care. Payers are the direct financial beneficiaries of an effective and efficient system of care, and they're the ones who take the financial hit when that system of care does not work so effectively or efficiently. They have the ability to create requirements and incentives for system-level efforts. Now, so far we've been speaking mostly about STEMI systems of care, but these issues are not limited to STEMI. Consider all of the other time-sensitive conditions and the fact that all of these time-sensitive conditions have a lot of issues in common. Yet, despite all of those commonalities, in most communities where they've at least progressed far enough to have some formal systems of care efforts taking place, they're usually working in silos. The surgeons have their trauma system of care group, and they meet on the second Tuesday. And quite commonly, each top-tier trauma facility in a region has their own separate trauma meeting. If you have 3 level 1 trauma centers, we're likely to see 3 separate trauma system meetings. Same goes for the STEMI meeting on the 3rd Monday. Same again for cardiac arrest on the 3rd Friday. And yet another day for stroke. Sepsis meetings are starting up too, and yes, on a different day at a different location. With all of the commonalities, is each top-tier hospital having their own separate system of care meeting for each different time-sensitive condition really the best use of everyone's time and resources? Now, because of these silos, our communities are missing a lot of opportunities for these teams to collaborate, share ideas, and encourage best practices. The trauma community has been working on systems of care issues for decades. Might there be something for the other time-sensitive care groups to learn from their experience? The other time-sensitive condition specialists have come into the systems of care arena with fresh eyes. They have some great new ideas and methods to offer. Is there some value in sharing that with trauma and the other condition-specific groups? we should have a way to effectively cross-pollinate ideas and solutions across all of these high-risk, time-sensitive conditions. So let's consider a new model, one that takes a multi-condition approach to organizing our systems of care efforts. And the key to this model is establishing a coalition, a regional time-sensitive care coalition of the previously disparate systems of care groups. The coalition should have representation from 911 communication centers, non-transport medical first response agencies, ambulance services, EMS regulatory and medical oversight agencies, and hospitals to include their emergency departments and acute specialty care services. But let's go back for a moment to our STEMI example. Our system of care efforts for STEMI went through all sorts of careful planning and painstaking implementation efforts to get the public to call 911, to get EMS on scene quickly, to get the 12 lead in the field, to do field interpretation of the 12 lead ECG and or transmit it to the hospital, to declare EMS STEMI alerts, mobilize the cath lab prior to ambulance arrival, have the cath lab team be ready to go by the time the ambulance arrives, to bring the patient directly to the cath lab when appropriate, to quickly get an angiogram, and then open the obstructed artery with placement of a stent. But after getting patients successfully through the acute care phase, we certainly don't want to have all of that effort to have been in vain by not getting their platelet inhibitor prescription filled, or not having it taken as prescribed, or not having other secondary prevention steps taken to prevent another MI. So, our time-sensitive care coalition should also include representation from rehabilitation and secondary prevention providers. And there's another extremely important stakeholder to consider, one that we previously mentioned that has a lot of leverage on how care gets delivered because they're the ones paying for all of it. We should include the major payers because they are the financial beneficiaries for more effective and efficient systems of care. There might be ways to share those financial benefits with the provider organizations through so-called alternative payment models or other ways the group might come up with. In this way, the consortium can take responsibility for making systems-level improvement for the full spectrum of high-risk, time-sensitive conditions and find ways to better align the clinical interests of patients with the financial interests of providers and payers. And I would include units of local government in this category. They also pay for much of the emergency response that is not paid for by insurance company. And they also directly or indirectly control the budgets of most of the 911 centers, non-transport medical first response agencies, and ambulance services in most communities. The coalition should also have representation from patients. They can provide a much-needed reality check and make sure that proprietary interests are not overtaking patient and community interests. So now that we have an idea of who to bring into the Regional Time-Sensitive Care Coalition, how might it be structured? The executive-level decision makers from the various organizations should be members of a steering committee for the Time-Sensitive Care Coalition. At this level, we want representatives that have decision-making authority or at least have very significant influence on financial and policy decisions. They need to come to the table able to make decisions and commitments on behalf of the organizations they represent. We would also have a condition-specific committee for each of the conditions that the steering committee has decided to take on. The chairs of those condition-specific subcommittees would be ex officio members of the steering committee, and each of the condition-specific committees would have their own condition-specific improvement project teams. But there should also be a place for discussing issues and conducting improvement projects that address issues common to more than one condition, and that cross-condition committee can have its own cross-condition improvement process teams. Once we start having the local time-sensitive care coalition meetings, the agendas can be pretty straightforward. The meetings can start with the subcommittees having their own respective breakout sessions before the steering committee session. Now, at the steering committee session itself, each of the time-sensitive conditions subcommittees can summarize their current performance levels. And this might be in the form of a performance index that appropriately combines their individual performance measures for their condition into a single performance index for that condition. The subcommittees can also report on their current QI projects and propose new projects that might encompass other time-sensitive conditions. This creates an opportunity to leverage what was accomplished in one subcommittee and apply it to other time-sensitive conditions if it wasn't originally conceived as a cross-condition project. The agenda then might look at the overall performance of the multi-condition time-sensitive care consortium using another index performance measure, one that combines the performance scores of each of the condition-specific performance indexes. This allows the consortium to have a single high-level metric that reflects on its overall performance, which will be particularly helpful for public accountability of the consortium. And inevitably, there will be other issues for the group to consider, and time on the agenda can be allocated accordingly. And there can be significant value in coordination and standardization of efforts and processes across all of the regional consortia. Rather than each regional consortium having to invent or develop its own measures and processes independently, there would be value in having some templates, tools, and uniform processes for the regional time-sensitive care coalitions to work from and adapt as needed to suit local needs, circumstances, and preferences. This is where the national professional societies and their state chapters could play very important roles. Many of these professional societies already support systems of care initiatives for the time-sensitive conditions that are part of their medical specialty. And for the same reasons that it's counterproductive for regions to work in silos, we should avoid the silos at a national level as well. And there's some very preliminary efforts underway to create a national level time-sensitive care coalition that would provide this kind of support and other resources that would be useful at a regional level. Such groups at a state and national level would also be in a better position to catalyze needed state and national policies and legislation and coordinate at state and national levels with payers and industry. The American College of Cardiology and the National Association of County and City Health Officials have already started working towards this goal. They have created a toolkit for state chapters of the ACC and local health departments to utilize in implementing this new multi-condition systems of care model. The first state chapter of the ACC to move forward with this is Tennessee, where efforts are already underway to implement this model. And one of the many elements in this toolkit is a checklist to help guide local champions that want to implement this model. One of the very first steps is to decide what area the regional consortium will cover. This may be a city, county, metro area, or a larger region that encompasses tertiary receiving hospitals and their associated referral hospitals. This may be adjusted later depending on which high-risk time-sensitive conditions are targeted, which institutions are willing to participate, where the hospitals are located, and where incoming ground and air ambulances come from. Next, take some time to identify any groups that may already be meeting or in the formation stages for commonly addressed time-sensitive care conditions. For each group identified, get contact information on the group leader. You'll want to include them on your mailing list when it comes time to schedule a meeting to organize the multi-condition consortium. The initial meeting of executives to consider forming the consortium may have associated expenses, particularly if a meal is to be served or a room has to be rented. Meals help getting people to attend, so finding a sponsor for the organizing meeting will be helpful. And there's a wide variety of possible sponsors ranging from healthcare provider organizations, regulatory agencies, local government, and payers to industry. So, working in conjunction with those organizational sponsors, determine when and where to have the first organizing meeting to discuss starting up the Regional Time-Sensitive Care Coalition. Priority should be given to the availabilities of leaders of any existing time-sensitive care groups and hospital C-suite invitees. Their attendance, input, and support is crucial. If there are a lot of people in this core group, give consideration to sending out a preliminary letter outlining the need for the meeting and ask they participate in a doodle poll or some similar method to identify their availabilities and choose the best date and time. And once that date, time, and location are determined, a follow-up letter with the specific time and location can then be sent out to the entire group of invitees. Now, when you actually have the meeting, consider who to use as a facilitator for the meeting. Ideally, it should be a neutral party so that all attendees feel their interests are not being diminished by real or perceived facilitator bias. A local health department or EMS regulatory official may be an appropriate choice if they have good facilitation skills. Having a high-ranking public official or major payer executive make some opening remarks to underscore the need for the coalition is a good way to get the meeting started. And they should also introduce the guiding principle for the meeting, that patient and community interests, the system's interests, need to be prioritized over the interests of any individual group or organization. And some of the outcomes to try for at that meeting should include a decision on formation and support of the coalition, and then a decision on which time-sensitive conditions to initially include with establishment of the appropriate subcommittees. And try to secure commitments for having a single executive-level representative from each organization serve on the steering committee, and get all to agree to send names and contact information to the organizer on persons from their organization to include on these condition-specific subcommittees. And there may be some discussion on the organizational structure itself for the coalition. The group might decide to keep it as an informal coalition, or they might decide to make it a formal legal entity, perhaps a 501c3 organization. There might be an existing entity that can fill the consortium role, like an EMS regulatory agency or a public health department. Now, all of this might not get decided at the first meeting, so several alternatives may need to be explored and presented back to the group for final decisions. Now, as soon as possible after the initial coalition formation meeting, a follow-up letter should be sent out to all the attendees and those who were invited but were unable to attend. It should summarize the meeting's activities, decisions, and next steps. Now, assuming that the initial coalition formation meeting led to a decision to start the coalition, the condition-specific subcommittees for the targeted conditions will need to be established or assimilated. And some new condition-specific groups may be started now or later for conditions that did not already have a system of care group in place. And regardless of the type of organizational structure that's chosen for the Regional Time-Sensitive Care Coalition, a set of bylaws or similar documents should spell out how the coalition operates. It needs to address how the steering committee and subcommittee members are appointed and rotated, how decisions are made, and other operating policies. A more formal and comprehensive set of bylaws will be needed if the coalition is going to be a fully independent 501c3 not-for-profit corporation versus an informal coalition. And this should be an early agenda item for the steering committee if it was not decided at the initial formation meeting. Another early issue for the steering committee is consideration of startup funding needs, developing a budget, and identifying an ongoing source of funding to make it sustainable. Again, an informal coalition will have different needs than a formal 501c3 structure. Funding options may include annual funding assessments to the participating organizations. Grants may be helpful initially, but may not be appropriate for the long term. And with an informal organizational structure, participating organizations may simply agree to share costs on an ad hoc basis or rotate the responsibility and costs for hosting meetings, etc. So, that gives you a small taste of what's in that ACC toolkit to help your regional time-sensitive care coalition get up and running effectively. The ACC is looking for more sites to participate as early adopters for this model and to whom they can provide some support. We also hope to publish and present in appropriate academic venues on these early adopter site experiences and results. So if you're willing to put in some time and help your region become one of these early adopter sites, please reach out to me directly via email. So that's it for the didactic portion of the webinar. Let's get some perspective from our commentator, Tim Phelan.
Excellent. Well, before we jump into the discussion part, just want to remind everyone that even though this isn't live, you are not only permitted, but you are encouraged to send questions and comments to Mick. So it's Mick, M-I-C, Mick at improvethesystem.com. And he will do his best to respond to every single question and every single comment. So, well, I just got to start off by saying this, Mick. I have gotten so much mileage out of Dr. ACKOFF's example with the car. We saw that at one of your previous webinars, and I just thought that was absolutely brilliant. And I've found opportunities to work it into all kinds of situations here. So let me just ask you this. That case that you're trying to make, is that absolutely well accepted, slam dunk? Everybody understands the system approach, or is it still, after all these years, some things you have to set as the groundwork expectation with people?
No, I think it is something that people still don't generally have a strong handle on. And I think one of the reasons for that is that there's a lack of system level performance measurement. When the only thing on your dashboard are metrics about your individual hospital or your individual emergency department or cardiac cath lab team or your ambulance service or 911 center, and it never really rolls up in an aggregate way to see how the overall system worked for an episode of care, much less how the regional system, looking at the entire STEMI system of care for your region, with all hospitals and all EMS agencies, how well is it serving the community overall? We just don't commonly see those kind of metrics out there. So it's easy to lose sight of the system and get really kind of, overly focused on your metrics and lose sight of the bigger picture of this is all supposed to be about the patient and serving the community. And that's where I think things tend to get lost in translation, unfortunately.
And I can see it happening. It's so easy to do. So you can tell me if this is actually urban legend or if this is true. It's kind of in that same vein. I'd heard there was a certain fast food chicken franchise that shall remain nameless that when they looked at all the customer comments, they didn't have a problem with the food quality. It was just how long it took to serve the chicken. And so they developed this system where they were going to measure their door to chicken time. They knew when the order was placed. They knew when the chicken was served. And the managers were going to be incentivized, and there was going to be data, and they were going to fix their problem. Well, like a quarter later, they have the fastest time ever for serving their chicken. However, they had a new problem. New complaint. The chicken is cold. So basically, the managers just figured this out. Oh, we're going to get paid on half-ass we serve it. Let's just make a whole bunch in advance and have it ready and hand it to them when they order. So they fixed the one problem, but obviously didn't fix the system. So any clue if that's actually a legit story or is it just urban legend?
I don't know for sure, but I could very easily see that happening in the real world where they get focused in this case on a single metric and forget that the purpose of their system is to give people food that they enjoy eating, they enjoy their dining experience, and provides them with a good meal. And that goal of serving it fast was one piece of it. But certainly isn't every element out of providing good nutrition and a good dining experience. So, I could see that happen, and you could easily see how, that example could translate into EMS.
Well, I'm going to go with it as true. Well, and here's where I'll sometimes use it. I mean, just as what you brought up in the video was just spot on. Is that when you're weighing in the balance, on one hand, you want to maximize the number of STEMIs identified correctly, but on the other hand, you want to have a reasonable amount of overcall or inappropriate activation. And the normal knee-jerk response is to just lean in one direction or another. And usually all that is a matter of the pain point, is the feedback the staff, that's the frontline crew, is the feedback they're getting. Wow, we're killing the cath lab with overactivations, or is the feedback that they're getting, hey, the worst thing you could ever do is to miss a STEMI? And so they sort of either serve the chicken fast or serve it cold, sort of based on what pressure, what feedback, what motivation they're getting. When in fact, that's, I am not trying to plug myself here, but that's the cornerstone of what I talk about is that whole model of critical thinking, so that you hopefully can maximize the number of correct STEMIs recognized while having an acceptable, not eliminate, but an acceptable degree of false positives. And here's where we're going to transition to what you talk about. So I'm putting forth a generic, plain vanilla model that's used by your average paramedic, average ED nurse, whatnot, to kind of, funnel these down, not to make the final decision. But I tell everybody that this only works in the big picture to the degree that it fits in with your current system. And I'm just fully aware that in my little short stint in any community, I can't really help them with that whole system picture, nor am I necessarily qualified to. So I thought it was particularly apropos for me anyway. I enjoyed your examples on this one, how you use the STEMI system, because that is definitely a real world situation. So what do you see more often, Mick? Do you see more often communities leaning more on never miss a STEMI and we're just going to abandon being concerned about false positives, or do you see them a little more worried about cath lab activation as their main goal, and they'll kind of just accept a certain degree of missed activations as the cost of doing business?
Yeah, in my observation, people generally try to do the right thing. And so there, I think, is fortunately a bias towards accepting overactivations because they're very fearful of a missed activation. The price of an overcall is an unnecessary, utilization of time and resources at the hospital with activating the cath lab and breaking open some sterile surgical packs and those sorts of things. And if it's off hours, the inconvenience of calling the staff in, but at least a patient didn't suffer harm. In contrast, if you miss an opportunity for an activation, you've lost a lot of time. Time is muscle, and muscle equates to larger infarcts and worse morbidity and mortality. So I think there is a bias towards that, and that's a good thing. But I think to the extent that people recognize system dynamics and can apply systems thinking, they can start working towards an appropriate balance between overcalls and undercalls. And that's all I'm asking for here, is to apply systems thinking and not try to just optimize the stats for your EMS agency and not just your hospital, or for an individual surgeon or cardiac interventionalist or stroke neurologist, whatever the case may be. We need to be focused on how well the system works, and not just within one ambulance service or one hospital, but is the system working well across all of the hospitals? And I think that's the big gap right now. And I'd be curious on your observation, Tim. In your travels around the country, how commonly do you see communities have all the hospitals meeting together to talk about STEMI or stroke or cardiac arrest or sepsis and these sorts of things?
It does happen, and I won't name names, but there are some communities that absolutely do that well and do that at a regional level. And the way I worded it was intentional. Do that well and do that at a regional level. That absolutely happens. But I think, as a guy who doesn't pretend to know all the ins and outs of every community, just with a couple little simple questions, you can usually get a feel for, is this truly an integrated effort? And so I'd just say there's still a whole lot of room for improvement there. And that's because, typically it's often motivated by a hospital or a hospital system that understandably needs to achieve certain goals and performance measures, and that's their motivation. And it kind of takes something above and beyond that to say, hey, we need to approach this at a regional level, because human behavior to a large extent is driven by self-interest, and individuals or institutions are going to first and foremost do what's going to make sense for them. And it really requires, not by default do people start thinking regionally. I think that has to be very intentional to introduce that.
Yeah, and where I've seen it, it is at the initiative of a local champion, somebody that understands that there's a bigger picture here. It's not just about my hospital or my interventional cardiology practice. It's about serving the community well. And whether it's a stroke neurologist that's trying to make stroke work well across the entire region, or a cardiac interventionalist, or a trauma surgeon, that's when this systems thinking comes to play and these regional systems get established. And what I'm suggesting in the video is that we see that in many communities, but those groups tend to work in silos, where there's a separate trauma meeting, a different STEMI meeting, a different stroke meeting, a different cardiac arrest meeting, and now there's different sepsis meetings taking place. And it just doesn't seem like a good use of resources with all of these groups meeting separately when they have so much in common. So have you been observing where you see a multi-condition regional systems of care strategy in many communities?
I don't know about many, and again, I'm not saying I'm privy to all that's going on. I do know that there are some that I've been extremely impressed by. So this absolutely does happen in some places. My hunch is it doesn't happen extensively, but it's not, what you're describing isn't some theoretical, unattainable goal. There are places that have been doing this for over a decade and doing it well, so it absolutely can be done. So now let me ask you a question here, Mick. So I'm an action-oriented kind of guy. All right. Let's just take a miniature topic, because STEMI is bigger, but ECPR. All right, you've got this cardiac arrest patient. Most cardiac arrest patients pre-hospital would benefit from doing insanely good CPR, ACLS, hitting those 5 points, on full chest recoil, right rate, right depth, no minimize pauses, don't hyperventilate. So we are hitting those 5 things, great. And we're just doing ACLS, great. So for the vast majority of cardiac arrests, that's what's going to increase survival, improve outcome. But there's that subset of patients that no matter what you do, it's not going to really benefit them, because what they ultimately need is to have a clot removed from their coronary artery. So the catch is that if those patients could be identified early, and an approach that is being looked at by more and more communities worldwide is identify those folks early, having met certain selection criteria, mechanical CPR, transport to the cath lab, ECMO, and cath them while in cardiac arrest. And in some of the publications, I mean, that subset that I described before has like less than a 5% survival rate. You follow that little approach and it could jump to 50. So long-winded question there to get to this. But you mention this to the cath lab, and the first thing they say is, oh my gosh, well, I can see the benefit. That's just going to tank our numbers, though. So there's the whole national effort required to change that. Here's the question. How would you begin to chip away at that locally? Somebody listening to this right now, how would they begin locally to just start to chip away at that situation?
That's kind of what I was making reference to in the video, Tim, was that the solution I see, taking a systems perspective on this, is that we have, first of all, our regional system of care for cardiac arrest, ideally as a subcommittee of a multi-condition regional system of care group. And within that cardiac arrest group, we recognize that problem. We recognize that concern about it tanking their individual numbers. And the reason they're concerned about the number is because it will make them look bad compared to the other hospitals. But if in that system-focused dialogue with the right people at the table, the interventionalists, the hospital CEOs, all the pertinent stakeholders in that conversation, they can come to an agreement that in order to make the system work well, we all need to accept these high-risk patients that meet certain eligibility requirements. And then no one has an unfair advantage over the other ones. No one's trying to game the system by avoiding the high-risk patients. They all come to consensus that we as a community need to serve these high-risk patients to the best of our ability, and they all agree to do it together. So no one gets an unfair advantage over the others. And the other thing they can do is just look at their data differently and separate out how well are we doing on these intra-arrest cardiac cath lab patients, or the post-ROSC cardiac cath lab patients, and the patients that are in the low-risk category where their care wasn't complicated by cardiac arrest at all or cardiogenic shock. And so I think if they look at the numbers differently, and if they all agree to work together to share the risk in the interest of serving the needs of the system, the community and the patients well, that will navigate them through that fog.
All right. So I like the concept. It just assumes certain things are already in place, I guess. So that's all I was saying, is that perhaps if the system wasn't in place and maybe using this as an immediate issue, that you could kill two birds with one stone. You could stimulate the whole conversation on the approach to these patients, and then bigger picture, begin to implement that kind of a regional approach where it may no longer, or may not yet exist.
Indeed. And but if you don't have that meeting with the different hospitals and ambulance services represented, you don't have the right venue to even have the conversation. So you've got a little bit of a chicken versus the egg scenario.
And that's really what I was trying to get at. What if somebody's listening and that's their case?
Maybe, I think exactly as you suggest, bring this point up and say this is exactly the kind of conversation that needs to take place, and we need to address this issue, and it points to the need for us to continue to have conversations as a region across hospitals and across EMS agencies to move the system of care forward.
Well, Mick, as always, we're out of time before we're out of questions and discussion. So, hey, just thank you for all the hard work that you are putting into this, Mick. It's making a difference. And for everybody listening, for more information about the new reports, the EMS reporting service for AMI, please visit acc.org/ereportsems.
And I'd like to thank Tim for being a moderator, or in this case, a commentator for our webinar today. Really always appreciate your participation here, Tim. And anyone wanting to contact Tim can do so by email at tphelan@mac.com, as shown on the screen there. And we'll also put up the contact information for Tom, and hope that he can join us next time. So on behalf of the American College of Cardiology and the Center for Systems Improvement, appreciate you being here. Share the link to this webinar with your colleagues as appropriate, and that will wrap up today's seminar. Thank you.